So let's talk about what a randomized placebo-controlled trial is, and specifically how it relates to anecdotal or testimonial evidence. What is a randomized placebo-controlled trial, or RCT for short? Let's say that a scientist creates drug X. He believes that drug X lowers blood sugar levels. He will need to prove that it works in a randomized placebo-controlled trial. He enlists the help of 1,000 volunteers who agree to participate in the trial. A computer will randomly divide up the 1,000 volunteers into two groups. One is the placebo group, and 500 volunteers are assigned to this group. The other is the drug X group, and another 500 volunteers will be assigned to this group. Neither the scientist nor the volunteers will know which group they were assigned to. Only the computer knows this and will keep this a secret until the study is unblinded at the end of the trial. The placebo and drug X look, smell, and taste the same, so no one will know which they are actually taking. When the computer is randomly assigning people to the placebo versus drug X groups, it will match them with respect to their baseline characteristics. What are baseline characteristics? So when randomly assigning to the two groups, the computer will ensure that there is a balance between the two groups in terms of a number of factors, including the average age of the people, their genders, other medications that they're taking, and other pre-specified characteristics. For example, a computer will randomly divide up the 1,000 volunteers into two groups with the following baseline characteristics. So in the placebo group that has 500 volunteers, the average age will be 55.2, whereas in the drug X group, the average age is about 55.1. So you can see that the computer did a really good job with matching the two groups for average age. In terms of their genders, you can see that the males and females are also quite relatively well matched between the two groups. Now, you have to also control for other things, so people will also be taking other drugs at the same time. So the computer made sure that people that are taking drug Y, that there's about 32% of people in placebo group versus 31% of people in the drug X group that are taking drug Y as well. Ditto for drug Z. So the computer also made sure that an equal number of people are taking drug Z in both of the two groups. Now drug Y and drug Z are not under study in this particular trial. So the reason that the computer is matching them both in both groups is to make sure that the difference cannot be said to be because of drug Y or drug Z. What this means is that there's really no other difference between the two groups except that one is taking drug X and the other is taking placebo. Drug X versus placebo. This means that any difference that we see between these two groups can only be attributed to being on placebo versus drug X. We can't say that it is due to any other factor because the baseline characteristics were balanced between the groups by the computer when it randomly assigned them to one group versus the other. So let's look at the results. Let's say that this trial was designed to run for 1 year. At the end of the year, we now analyze the results between the two groups. We'll call the groups A and Group B. Remember, neither the volunteers nor the scientists know which group is the placebo group and which group is the drug X group. So here's the results. People in Group A, again, we don't know whether this is the placebo or the drug X group, Their average A1C, which is a measure of how high their blood sugars have been over the last 3 months, their average A1C at baseline was 8.5%, but after being on either drug X or placebo, whichever they're taking, for a year, their A1C has come down to 7%. Their weight at baseline was 76 kilograms, but now at the end of the trial, 1 year later, it's 79 kilograms. At the beginning of the trial, about 4% of volunteers in Group A reported that they had a cough, and by the end of the year, 8% reported a cough. Similarly, 2% at the beginning of the trial said they had a rash, and by the end of the trial, 4% said that they had a trial. Now let's look at Group B, which also has 500 volunteers. Now, as far as their sugar average, their A1C went from 8.3 at the beginning of the trial to 8.1% at the end of the trial 1 year later. Their weight went from 74 kilograms to 75 kilograms. Their cough went up from 3% to 7% reporting a cough at the end of the trial. And lastly, 1% of people had a skin rash at the beginning and 1% of people had a skin rash at the end. So what are the differences between the two groups? Well, Group A, we found that there was a 1.5% reduction in their A1C, a 3 kilogram weight gain, 4% increase in cough, a 2% increase in skin rash. And similarly, in Group B, there was a 0.2% reduction in A1C, a 1 kilogram weight gain, a 4% increase in cough, and no change in the percentage of reported skin rash. So if you compare Group A versus Group B, in Group A there was a 1.3% lower A1C than in Group B. There was a 2 kilogram weight gain compared to Group B. There was no difference in the percentage increase of cough, and there was a 2% greater skin rash reported than in Group B. We now have to calculate statistical significance. Statistical significance calculates how likely it is that the difference between these two groups is due to random chance. By convention, we consider a result to be statistically significant if there is less than a 5% chance of the result happening randomly. Are these results statistically significant? Let's compare again Group A versus Group B. We said there was an 0.8% reduction in A1C, a 2 kilogram increase in weight, no change in cough, and a 2% increase skin rash. By convention, we consider a result to be statistically significant if there's less than a 5% chance of the result happening randomly. So what we find is after we've done the calculation of statistical significance, we find that the result of the 0.8% reduction in A1C was statistically significant between groups A and B. The increase in weight gain was also found to be statistically significant. In terms of the cough, since there was no change, this was not statistically significant. But with the skin rash, again we did the calculation and we found it to be statistically significant. We now unblind the study, and the computer tells us which volunteers were actually taking drug X versus which volunteers were taking placebo. We find out that people in Group A were actually taking drug X and people in Group B were actually taking placebo. After unblinding, we can say that these results that we found to be significant are due to drug X, because the only difference between the two groups is that they were taking drug X versus placebo. So we can say that drug X significantly lowers A1C levels, but it does have the side effects of increasing weight gain by approximately 2 kilograms, and there's about a 2% risk of developing a skin rash. However, the side effect of cough, there was no statistically significant difference between the groups taking drug X versus placebo. So we would say that cough is not a likely side effect of drug X. This is how scientific clinical studies are performed to determine whether a drug is effective and to weigh the benefit versus risk by determining the positive and negative outcomes. Because this process involves randomization, that is, the computer assigns each volunteer to either the drug X group or the placebo group, this eliminates a bias called the selection bias. Because this process involves blinding, neither the scientist nor the volunteer knows whether they're taking drug X or placebo. This eliminates detection bias and performance biases. This process of a randomized placebo-controlled trial helps us to reduce biases. This helps us understand the true effect of drug X, both its benefits and its side effects. Let's compare this with traditional medicine or alternative medicine or homeopathic medicine or natural remedies. These types of therapies usually rely upon anecdotal evidence. What's the problem with this type of evidence? Let's use some examples of anecdotal evidence, which are also called testimonials. This treatment works because it worked for me, it worked for my aunt or my neighbor or my friends, it worked for a bunch of people I know, it has been used for decades or centuries or generations, therefore there must be some truth to it. But these arguments are all flawed. There are several problems with this type of anecdotal evidence. There is recall bias, there's availability bias, there's confirmation bias, there's observer bias, there's confounding bias. Let's look at each one of these. Recall bias. Recall of information depends on a person's memory, which can be imperfect and sometimes unreliable. People are much more likely to remember certain types of events and forget others. If someone feels better from some ailment after taking a particular vitamin one time, they are more likely to remember that than other times when they took the vitamin and nothing happened. Availability bias. Infrequent events are usually more easily or vividly recalled, and so individuals tend to overestimate the power and frequency of that event. For example, a snake bite to someone we know is a very rare event compared to diabetes, heart attacks, or stroke, but we are much more likely to remember the snake bite incident compared to the others. Similarly, if one person we know was on the brink of death but recovered after taking some special vitamin, we are more likely to remember this than numerous others that are still alive because they took a regular antibiotic, which is a common occurrence. Confirmation bias. Confirmation bias is the tendency for people to interpret, favor, and/or recall information in a way that affirms one's prior beliefs or hypotheses. If a person believes that vitamin X cures disease Y, they are more likely to interpret or recall any results in a manner which suggests that vitamin X cures disease Y. This kind of bias cannot occur in a randomized placebo-controlled trial because when the scientist is interpreting the results, he or she does not know whether people in group A or group B have taken drug X versus the placebo. Observer bias. The observer, scientist, healthcare practitioner has a tendency to see what they expect to see or what they want to see. They may come to an experiment with prior knowledge and subjective feelings about a particular treatment. Dr. X believes that smart vitamin makes you smarter. He or she will thus be prone to interpreting any results or outcomes from this perspective, which can bias the results. This bias may be overt or it may be subconscious. Confounding bias. One of the most important biases in anecdotal or testimonial evidence is a problem of confounding bias. Here's an example. Susie performs poorly on her math test. The next time she takes a math test, she takes a smart vitamin before the test. She does very well on the second test. Susie then assumes that the smart vitamin makes you smarter and helps you get a better result on a test. However, what Susie is forgetting is that there might be a number of confounding variables that actually resulted in her getting a better score on her second test. She might have studied more for the second test after performing poorly on the first. The second test might have been easier, or it might have covered subjects that she knows better. This bias is reduced in a randomized placebo-controlled trial because remember, people were split into two groups randomly, and the only difference between the people in the two groups is taking drug X versus placebo, and therefore if differences are found between the two groups, it can be inferred to be due to taking drug X versus placebo. So for example, if this prior example had been designed as a clinical trial with 1,000 volunteers, let's say that all 1,000 volunteers were selected that had performed poorly on a previous math test and they're about to write another math test. Let the computer split them into two random groups, Group A versus Group B. One group is given this smart vitamin 2 hours before their test. The other group is given placebo 2 hours before their test. Let's say Group A and Group B both on average do 25% better on this test than they did on the previous test. In this case, clearly it wasn't the smart vitamin that caused them to do better, since people taking the placebo also did just as well as the people who took the vitamin. There must be a confounding variable that is responsible for the better score this time compared to the previous test. For example, everyone tended to study harder for the second test after performing poorly on the first test. This would be a confounding variable. This is how a randomized placebo-controlled trial reduces confounding bias. By having a placebo group, we can determine whether the difference that is found is due to the treatment or some other factor. The problem with naturopathic, homeopathic, and alternative medicine. It's not that they do not work. This is a very, very common misconception that people believe, that healthcare providers believe that these medications or treatments don't work. That's not the problem. The problem is that we don't know if they work or not because of the inherent biases that are present in anecdotal evidence without a randomized placebo-controlled trial. And even if they do work, we don't know what the short-term or long-term side effects are. A particular treatment does not have to be artificial, created in a lab or industrially, expensive, created by a pharmaceutical company, for it to work or be effective. But it does need to be proven, preferably in a clinical trial which minimizes these types of biases that we discussed. So for example, let's say if lemon water, so just lemon squeezed into water, cures cancer X. And this has been proven to reduce cancer X in a randomized placebo-controlled trial where one group was given placebo, something that tastes exactly like lemon water but has no actual lemon in it, and the other group was given actual lemon water. And the lemon water group was shown to have less cancer X than the placebo group. Then lemon water would no longer be considered an alternative or homeopathic or naturopathic medicine. It would be considered standard medicine or standard medical therapy, and healthcare providers would gladly promote it. So the difference between medicine and alternative medicine is not the use of chemicals versus the use of natural substances. The difference is only that one has evidence in the form of a randomized controlled trial and the other uses anecdotal or testimonial evidence, which is inherently flawed. So you can see why healthcare providers prefer therapies and drugs that have been tested in randomized clinical trials as opposed to naturopathic or homeopathic or alternative treatments that rely on anecdotal or testimonial evidence of my grandma said this works.